Who's all been involved in a branch stent graft to date? Hands up. So not that many. Okay. So let me tell you a little history first of all. I mean, one of the things that really attracted people of my vintage into vascular surgery was fixing the aortic aneurysms. There was nothing quite like the abdominal operation, clamping that thing, slitting it over and taking the thrombus out. It was kind of that aha moment. And we're doing a lot of them. I mean, these are sort of things we'd be doing 5 to 10 of these a week. Then along came this crazy guy called Juan Perotti. Juan Perotti, everybody know what Juan Perotti is? Juan Perotti is an Argentinian vascular surgeon. Did he work in a big university center? No, he worked in his own little office with his interventional suite. And he kind of took the idea from Julio Palmas. Anybody know who Julio? So these are names you should know. Juan Perotti, Julio Palmas. Anybody know who's Julio Palmas? Pardon? Palmas Stent. But what was he and where did he live? San Antonio interventional radiologist. So he made this piece of chicken wire, piece of stainless steel, and developed the idea of a stent. That's a pretty good thing to have your name on, trust me. And so then Dacron. I'm sure you heard the Dacron story. Dacron wasn't invented here because DeBakey was looking for something to fix an aneurysm with. He went down to Foley's department store, which was downtown, happened to have closed subsequently, but he was looking for Vignon N. And they said, we don't have any, but we got this new material called Dacron. What do you think of that? So he takes it out, looks at it, it's there for dressmaking, and said, hey, this looks pretty good. Give me a roll of that. And he took it home and sewed it up into a tube. And he said, I heard him present, he said, I applied to the IRB for permission. That was me. I gave myself permission, and they put in the Dacron graft. And to this day, Dacron's probably the most important material. So then you had Palmas stents from Julio Palmas. You had Dacron, Foley's department store. And what Juan Perotti did was he sewed a Palmas stent onto a Dacron graft, and he decided that he would use this for high-risk patients with high-risk aortic aneurysms, and so they needed a neck. Okay, the first concept really is shown here is they needed a neck, a normal piece of aorta below the level of the renal arteries. When you screen a patient in the office, that's what you're looking for. If you got a neck, you can fix this. If it's don't have a neck, it's not that you can't fix it, it becomes a lot more complicated. And so what Perotti did was build basically a delivery system, and he used a Palmas stent on the balloon, blew it up below the renal arteries, then he put a second Palmas stent in the bottom and blew it up, and so he could only tube grafts. And that's how the first stent grafts were developed. Then US device manufacturers came along and said, aha, Perotti patented nothing, okay? Palmas was a lot smarter than Perotti was in this respect. Perotti owned none of the IP for this. It was all then, it was observed and it was developed in the United States. And the first two stent grafts that came along were from a little company called EVT, Endovascular Technology, and a slightly larger company called Medtronic. Medtronic built the original ANEURYSM graft. And, we were involved in both of these trials when I was at Emory. And we learned things from these early failure modes because on the ANEURYSM graft was a fully supported graft, stents the entire length, but no hooks. Okay, the guidant graft had hooks to engage into the aortic wall, but no longitudinal stents. And so what happened is that you kind of learned from the failure modes of these devices that the ANEURYSM graft, what's now called active fixation, which all of the current grafts actually have some way of driving fixation into the wall, works perfectly. And what happened with the ANEURYSM grafts is because it depended upon the hoop strength of the stents, they migrate over time and they drop. On the other hand, the EVT grafts, because they didn't have stents in the limbs, had a very high incidence of limb occlusion. And so you ended up basically putting extra stents, wall stents, inside the limbs, and that made a difference. And so you learned that the contemporary stent grafts all have active fixation and fully supported along the entire length of them. And that's really where we're at, at the moment. So, these patient selection criteria almost change, on a monthly basis at the moment. This is kind of how it started, is you wanted a 10 to 15 millimeter neck, minimal angulation, and distal iliac fixation. You needed a proximal and distal landing zone. Tortuosity complicates things. Thrombus within the aneurysm and calcification complicates these things. And although this has made it easier to treat patients, it really shouldn't change our indication. And that's one of the things I think the vascular surgery community has done a really good job in sticking to, and that we you know, we kind of tongue-in-cheek tell the joke, the old ones are still the best, basically, Jason said, you know, the 4-centimeter aneurysm is the most dangerous one around, but, you know, by and large, 5 centimeters, 5.5 centimeters, we're going to fix them. 4.5 to 5 centimeters, you kind of individualize that. And in a small woman, it may be appropriate, and somebody that's had enlargement over a short period of time, it may be appropriate. And some patients are just drives them crazy knowing they've got an aneurysm, and they dwell on it, and they can't function. And again, those are situations, but by and large, we stick to the indications. A good piece of information to have in your mind, most aneurysms grow on average 0.4 centimeters a year, but that's an average. Aneurysms also show staccato growth. Sometimes they grow, you know, more or less linearly. Sometimes they show this staccato growth. But it's, you know, if you see, you know, a relatively young man basically who's got an aneurysm that's 4.5 centimeters, he's going to get that aneurysm fixed because none of the stuff you just heard from Jason is going to prevent this really from getting bigger. But the issue with smoking is a board question. It correlates more with progressive aneurysm enlargement basically than anything else that actually that is out there. So stop, and that's another little pearl to tell patients. If they don't want you to be in the belly at some point in time, stopping smoking is the single most important thing that they can actually do. So we've talked a little bit about some of the guidelines. I depicted the idealized proximal neck, but sometimes they taper, sometimes they reverse taper. All of these things, you know, correlate with a higher failure mode and higher migration rate. And so we've all continually pushed the envelope a little bit in terms basically of the quality of the neck. And now the big question you're going to be faced with is, when is the neck not good enough for infrarenal repair, and now you need to start considering putting branches into the renal arteries? And that's an open question. Nobody really knows basically what the answer is to that at the moment. So here's an aneurysm you'll never see in your entire career. You'll be lucky if you see something like this. But you know, the other aspect that I haven't talked about is because the common iliac arteries you can almost always handle. Now we got bell bottoms that take, you know, what are essentially aneurysms and treat them. But the other challenge you're going to have is the access vessels. That is an ongoing problem and an ongoing source of complications. And many of those lessons we learned, now we're relearning them again because of the TAVR programs. But the tortuosity, calcification, and small vessels are kind of a recipe for disaster when you're trying to drive some of these big sheaths basically up there. And this basically looks at the 5-year post-EVAR rate of sac enlargement. And so the big issue that we deal with, of course, is type 2 endoleaks. And that's a conversation you're going to have. About 20-30% of patients you're going to see. Everybody know what type 2 endoleak is? Type 2 endoleak is basically retrograde filling into the aneurysm sac through the lumbars. Now, again, normally you do it open. First thing you do, clamp, cut it open, scoop out all the blood clot. Next thing you look in the back of the aneurysm and all these little geysers that are coming into the back called lumbar arteries. Who cares about lumbar arteries? Well, you're going to care a lot about lumbar arteries. These same things that we used to just ignore, oversow, and sacrifice, now are the big bugaboo in stent grafts and managing the empty sac, because they vary between being completely absent because they're all thrombosed to being hose pipes that are coming in the back. And those are the hose pipes that are probably big enough or numerous enough to pressurize the aneurysm sac. And that's basically when a type 2 endoleak becomes significant. And there's a whole industry has been developed around basically managing these. So you've now got, say, 5 or 6 different endografts. It doesn't really matter. They all work pretty well. You're not going to learn to use them all. Choose 1 or 2, get to know the reps, get to know the people who are going to support you, and get to know the nuances basically of those devices. Because keeping in your mind basically what the various different components of is frankly almost impossible. The advent of endoleaks, of these endografts, I should say, transformed our specialty. So again, what happened is that, you know, you think about it now, but all of a sudden, you know, the operation that defined and drove most of us to go into vascular surgery was about to go away. And so these companies did us a major service because they kind of demanded that a surgeon and a radiologist make a team and basically get trained on this. So they'd take us up to Utah and they'd train us on cows. We knew nothing about catheters and wires and things. We used to do a completion angiogram after a fem-pop, flat plate underneath the patient, inject some dungite, they shoot a flat plate, their technician would run down an x-ray, they'd come back and they missed it. There would be no dye on there. They'd do it again. And so it would take longer to do the completion angiogram than it would take to do it. And so what happened with the advent of endografts is all of a sudden you had pretty high level imaging in the form of portable C-arms moving in the operating room. And we learned about DSA, we learned about contrast. And there's a radiologist there who was teaching us about wires and catheters and stents, because we had put the stents in these limbs. And then one day, the radiologist couldn't come. Well, we just kind of kept on trucking. And they blurred these margins in the operating rooms of things that we had never done to things that we did with help. And then all of a sudden the help wasn't there. Nobody really even noticed that the help wasn't there at that point in time. And so this completely changed the paradigm basically for what we were doing, and basically allowed us to get involved in these procedures. And so it also transformed imaging. It is what made us learn about CTAs, 3D reconstruction, and measurements of that. And so it is such an integral part of what you're going to do on a daily basis. And preoperative selection for these patients is the most important thing you see that you're going to get moving forward. Because if you don't, you can get all sorts of complications. This is a complication I hope you never see. It's where we overdilate the proximal neck. And I've never actually seen this, but it's something that you don't really want to have happen, because it's very difficult to handle. Is if you overdilate the proximal neck and you rupture the aorta, that generally means you're going to have to operate on the patient, and most of these will not actually survive. So knowing the diameter of the aorta, upsizing the endograft within the manufacturer's specification, usually with the order of 15–20%, is extremely important. Here's a patient who's got what can only be described as a big-ass endoleak coming around, and you can get a pretty good idea of what these endoleaks are coming from, because this is why we have to follow these patients up. It's not, the stent graft, by and large, is working pretty well. But what happens is when you put the stent graft in, patients always like to be told that their aneurysm's gotten smaller. And we kind of like to tell them your aneurysm's gotten smaller. That's probably not the best thing. It's probably best if it stays exactly the same as it was when the stent graft was put in there. Getting smaller, aneurysm shortens, and it bends the endograft. And it's one of the reasons we've got to follow these patients, because it can dislocate overlapping components. That's a type 3 endoleak. Or it can break what was previously a proximal seal, in a type 1 and create something like a type 1 endoleak. This is probably a type 1 endoleak or a type 3 endoleak. And sometimes there are fabric defects that can actually occur, where in some of the original grafts, and there's a great ANEURYSM picture that Ken Oriel published, where each one of those pieces of the stent is actually hand sewn onto the graft. So there's a little suture that goes around them. And over time, as with motion, those sutures would widen the holes in the fabric. And there's a patient that he explained, an incredible video. They open it up, and there's dozens and dozens of little geysers coming through the wall of the stent, of the fabric, where the threads basically of the suture had actually opened them up. So all sorts of lessons have been learned in the evolution of the development of these stent grafts. So you kind of need to know and take something like this. Open conversion, these are not easy things to do, actually. Again, let's break it back into the different reasons that this can actually happen. Is type 1 endoleak you need to fix. Those are high pressure endoleaks. They're going to get bigger and they're going to get worse. So it's not something that you're going to sit on. Having said that, I've got a title that was given me at Viva's, which type 1 endoleaks can you watch? And generally the answer to that is none. It's broken down to type 1A proximal, type 1B distal. You kind of have to individualize. If the graft is migrated, you've got a seal zone, you can usually treat it. But sometimes you're going to have to take these endografts out. And this is where you guys have got a big problem, because this is what you're going to be doing. And almost all these patients that were doing aneurysm repairs have had some sort of endograft put in them beforehand. And depending upon the endograft changes the complexity of how you're going to approach this. And when they've got big, and disappeared. When they've got great big suprarenal stents, it can be very challenging to take that out. So we're running an open aortic training course about taking endografts out here in October sometime, because you don't need training in endovascular stuff anymore. You're going to need training on open components. So we've kind of, each manufacturer has got its own sizing chart. You kind of go through that, you fill in the forms, and it translates into the different types of aortic component, limb component, and extensions that you're actually going to be utilizing. If you're going to do the branch aortic endografts, and again, very similar, each company has its own sizing chart, but now you add a new dimension onto it. Now you add a dimension on the clock face. If you're looking up the aorta, where do the renal arteries come off? Do they come off at 1 o'clock and 10 o'clock, or do they come off at 3 o'clock and 9 o'clock? These are all critical measurements that are being made. You plan these things wrong, you design those branch stent grafts badly, You're in for a long day in an operating room trying to navigate between an offset renal artery and the renal artery target. So typically the workup, ultrasound, CT is what you're going to use basically for sizing these, because it allows you really to draw a center line, calculate true diameters. If you get it off axis, like for example an A, it may look like the diameter is much higher than it is basically if you get it perpendicular to the center line. So these logarithms really are all out there. Get used to working in the multiplanar reconstruction space. You need to be able to work in MPR. That's the single most important thing I think that you can learn to do. The other thing about CT scans is that in the past, CT scan was something you put up on a monitor, you looked at, and then you looked at the patient. That's not the way we use them. The CT scan that we judge the patient on in the office is fused on top of that patient in the OR, and we navigate and implant an endograft based upon the dye that Mrs. Smith had, a month ago. So the quality of these CT scans basically is extraordinarily important. So if I'd say a couple of things about this, learn to do 1 or 2 endografts, learn to use it well, get to know these device reps well. They've seen a heck of a lot more than you have, and they can really help you under difficult circumstances, and work in the multiplanar reconstruction space and learn how to interpret work with these images.